So my name is Bill Hitch. I'm the Director of Pharmacotherapy at the Mountain Area Health Education Center in Asheville, North Carolina. And I want to tell you a little bit about clinical pharmacist practitioners, or CPPs, which is a license that pharmacists can get that allow them to prescribe, initiate, titrate, discontinue certain medications, also draw labs that are important for patient care. So I'm a clinical pharmacist practitioner, and my license is mostly related to anticoagulation and management of blood thinners for patients in the outpatient setting. And so we have a primary care clinic where I would see patients and manage their blood thinners to make sure that we're decreasing their risk of clots, strokes, while at the same time decreasing their risk of bleeding, which is a complication that can be associated with these blood thinners. So it requires some continual monitoring, adjustment, and that's what we do in the outpatient setting. I manage a department of 5 clinical pharmacist practitioners, so all of my pharmacists are CPPs. And what that allows my department to do is really manage patients in a different way. And so a lot of my pharmacists work in the ambulatory care or primary care setting, so they work in a doctor's office, and they're seeing patients with chronic disease. So they're managing patients with diabetes, with high blood pressure, with cholesterol issues, with osteoporosis, chronic pain, many chronic diseases that our patients face. So this license allows us to work collaboratively with physicians, and so our physician colleagues will diagnose patients with these disorders and then refer them to our clinics where we can assist them in the management. And as you think about healthcare in this country, we have baby boomers that are the largest portion of our population, and those patients are starting to access care in a much larger way. They're starting to leave the workforce and starting to need more care from a healthcare perspective. So it creates a potential challenge with healthcare, especially in the primary care arena, that we're going to have a shortage of primary care physicians, and there's going to be a number of patients that we have to help manage. And there's just going to be a limited number of people to be able to do that. And so the CPP license allows us to assist our physician colleagues to work together to see some of these complex patients with chronic disease that can free them up to see other patients with acute illness. And so in that way we can collaborate together to extend our care to patients that currently aren't having it. So clinical pharmacist practitioners are really going to allow us to treat patients with chronic disease in a different way that allow pharmacists to be able to utilize their extensive knowledge of medications to be able to help improve the lives of our patients and to help care for these patients in the approaching primary care shortage and crisis. So in the legislature, there is a bill in the House and in the Senate that would allow pharmacists to have what we call provider status. And this would list pharmacists as providers under CMS, so under Medicare. And what this would do for pharmacy, there are a number of things that I think are incredibly positive about this bill. It changes the way that reimbursement occurs, and so billing for pharmacy services would now be something that we would be able to do and bill at the level of service provided. And so pharmacists that are working in a clinical setting currently have been billing in a variety of different ways, something we call incident to, so utilizing our physicians and billing incident to them. But really what's happening is that our pharmacists aren't able to bill at the level of service provided, which means that our pharmacists aren't able to sustain a healthy business model that would allow pharmacists to be able to be in the majority of primary care clinics. And so the billing structure limits what we can do in terms of putting pharmacists into physicians' offices all over the country. And so provider status is something that would allow primary care physicians and in turn patients increase access to clinical pharmacy, which can help patients who have chronic disease, who are on a number of medications, that now they would have access to a clinical pharmacist who could take care of them in collaboration with their physician and improve outcomes and improve their health.
I'm Scott. I'm the Regional Associate Dean for UNC Asheville School of Pharmacy, and I also practice as a clinical pharmacist practitioner at Mountain Area Health Education Center. I have been a family medicine pharmacist for almost 20 years and have practiced as a clinical pharmacist practitioner since the legislation was passed. I've worked in many different clinics in family health centers, and most recently am working in pharmacotherapy clinic and in osteoporosis clinic. So our osteoporosis clinic is a clinic that focuses on patients who have abnormal DEXA scans who are coming in to be evaluated for their risk for fracture. And we have a team of people who work together, including a nurse, a physician, and a pharmacist. And we are there to tune up patients' medications and make sure that they're not falling and make sure that we're doing everything for them to keep them from having a fracture. So my role in that clinic is to do a complete medication review to assess medications that might cause falls and to make recommendations and sometimes changes to their drug therapy to get them off medications that might make them fall, like benzodiazepines or tricyclic antidepressants. We also do, as a pharmacy team, a review of diet and supplements for calcium to make sure that they're getting adequate calcium, and also make recommendations to the patient about changing vitamin D dosing to ensure that they're meeting American Geriatric Society guidelines. And then we help with choosing a medication for treatment of their osteoporosis, whether it's a bisphosphonate or teriparatide or denosumab and others. And we go in and we implement that plan and make sure the patient knows all the changes that they're going to be making for that day. The other clinic that I work in is pharmacotherapy clinic, and pharmacotherapy clinic involves a lot of different types of patients, including patients with diabetes, particularly those with type 2 diabetes, and patients with gestational diabetes. We also do annual wellness visits as part of that clinic, and that's where I see my anticoagulation patients as well. So we use a lot of warfarin still, but we're using a lot of the novel oral anticoagulants as well, and collaborating with dentists and surgeons as patients are getting ready to have procedures, and also doing transitions and care work as patients go into the hospital with DVT or pulmonary embolism and they're transitioning back home to make sure that we're treating them adequately to prevent bleeding and to prevent clotting. I'm really excited about the provider status legislation because I feel like this is something that our profession has needed for a long time, and it would really help to advance what we do and increase the recognition of what the pharmacist can bring to the healthcare team, and certainly also creates a payment mechanism because reimbursement for cognitive services has been a barrier to expansion of innovative ambulatory care models across the country. So if provider status passed, there's a lot of things that I think would be different for me as a CPP, and then also different for our practice and different for the profession. I think for us it would enable us to be able to provide the services that are most needed for patients and that are most needed for population management with healthcare reform, instead of relying on certain types of visits that we know are going to help to create financial sustainability models. So it would open up the opportunities for us to do more things than what we're already doing. I think it would also solidify financial models in our practice. We're often having to think about grants or think about support from the School of Pharmacy in order to sustain some of the work that we're doing. And so I think it would just, again, free us up to be more financially stable and to be able to expand the model beyond what we're already doing. Now, for other parts of our region in Western North Carolina and across the state and even across the country, I think what it would do is open up doors for practices to hire pharmacists who have never had pharmacists before. payment is the number one barrier to having pharmacists incorporated into patient-centered medical homes. And so I think that having recognition as a provider with a sustainable model, it would enable practices to be able to hire pharmacists and for pharmacists to be able to do the work that we are already trained to do. I think in some settings, like federally qualified health centers where pharmacists are not allowed to do certain tasks because they're not recognized as providers, in those environments it would also enable pharmacists to be able to do things they've not been able to do before because they weren't on the list as providers. So I'm hopeful that this legislation will pass.
Hello, I'm Elizabeth Michelet, Regional Assistant Dean of Clinical Affairs for the UNC Eshelman School of Pharmacy and a pharmacist at Mission Health System in Asheville, North Carolina. I have been a hospital pharmacist for nearly 25 years and a clinical pharmacist practitioner, a CPP, since 2001. I've been told that I was the first inpatient CPP in North Carolina. By far, the majority of CPPs are practicing in the ambulatory care setting. However, I'm here today to talk to you about and describe for you a couple of practice models for inpatient CPPs. At Mission Hospital, our critical care teams are interdisciplinary in nature. And in fact, nationally, critical care teams have been interdisciplinary for well over 25 years. Likely due to the high complexity of these critically ill patients, the high volume of medications, and the expertise needed to care for these patients. So our critical care team in the neurotrauma ICU at Mission Hospital cares for 14 critically ill patients on a daily basis. Many of these patients have life-threatening injuries and complications. The critical care team consists of the trauma surgeon, the bedside nurse, the pharmacist, and the respiratory therapist, and we work as a team to ensure the best outcomes for patients. The CPPs in this setting play a major role in pain, management of pain, management of agitation and delirium, treatment of healthcare-associated infections, prevention of DVTs, electrolyte replacement, glycemic management, and evaluation of patients' home medications, which ones should be continued during their hospital stay, which ones should be discontinued, and prevention of drug interactions. So as a team, working hand in hand, we can ensure the best medication outcomes for these patients. The CPPs in this ICU setting have prescriptive authority, and our collaborative practice agreement includes all of the medications on the hospital formulary, and we're also able to order medications and assessments for appropriate monitoring of these medications to ensure the most successful outcomes. And in fact, we published a study in January 2015 in the American Journal of Health System Pharmacists, collaboratively with the Director of Trauma Surgery and Critical Care Medicine, Dr. Bill Schillinglaw, describing our outcomes from a 2-year expansion study of the CPP model. And in that study, we saw over 2,100 patients over a 2-year time frame, which included over 13,000 medication encounters. And with the expansion of the CPP model, we observed a 75% reduction in prescribing-related adverse drug events for patients, along with a 37% reduction in adverse drug events that were of higher severity. Along with the CPPs improving safety outcomes for patients, we also observed nearly a $2 million cost savings in the patient's medications using national benchmark cost data that we use for comparison. So clearly the CPPs, those of us who practice in the neurotrauma ICU, our work collaboratively with the interdisciplinary team not only results in improvement in safety outcomes for patients, but also a cost savings. So our CPPs in the ICU at Mission Hospital are not the only inpatient CPPs. Our pharmacists who work in the emergency department also are CPPs and work collaboratively with the emergency room physicians. They play a number of roles, but I'll describe for you one of the important medication management services that they provide for patients in the emergency department. The pharmacists are the primary providers for antimicrobial antibiotic follow-up for patients who've been discharged from the emergency department. For example, when a patient leaves the emergency department with a prescription for an antibiotic, then the pharmacist follow up on the culture and sensitivity results for those patients after they leave. And they call in a different prescription and call the patient if the culture and sensitivity results indicate that the antibiotic needs to be changed for the patient. So another example, a pharmacist in the inpatient setting actually functioning as providers for these patients. So in summary, these two examples that I've described for you regarding an inpatient CPP model, you can see that the pharmacists work on an interdisciplinary team to ensure safe and effective medication outcomes along with a cost savings for our patients who are in the hospital. So provider status for pharmacists has been a hotly debated topic as long as I can remember, but definitely for the last 10 to 15 years. And clearly, I think the impact of provider status will have a larger impact in the ambulatory care setting than it does in the inpatient setting. However, I think it's important. And so going back a few years, the inpatient pharmacist at Mission Hospital, we were charging for our clinical consults and our disease management activities up until about 10 years ago when Medicare laws changed. And I think it's important to examine the business model for a pharmacist in an inpatient setting. Our business model is that all of the charges and accounting for the time that a pharmacist spends with a patient is really focused on dispensing the medication product, and there's really no room in terms of time compensation that the pharmacist spends at the bedside with the patient and with the team providing disease management services for a patient. So we do feel like the dispensing and the medication product are the foundation of what we do, and is important, but it's really not built into justifying the pharmacist's time, the extra time that it takes to ensure that the patient is receiving safe and effective drug therapy, and the drug therapy management contributions that a pharmacist makes for a patient while they're in the hospital. I think it's interesting that we've done a study internally looking at how many medications patients are on when they do come into the hospital. And last year, looking at nearly 1,000 patients, our patients are on a median of 10 medications per patient. So if you think about the importance of our aging population across the country and the fact that patients are on even a median of 10, meaning there's some patients that are on more medications than that, some less, the complexity of medication regimens, it can be very challenging for the healthcare team, and a pharmacist is needed to, as I talked previously about the results of our study, a pharmacist is needed to be part of the provide drug therapy management, and this is not accounted for because pharmacists haven't been given official provider status and are not recognized as actual healthcare providers for patients. So I think with the passing of provider status legislation, I think other speakers have showcased the benefits in the ambulatory care setting, but in the inpatient setting, it would help us to justify and ensure that we always have a pharmacist who's part of the team and whose time is justified in the business model for being able to provide that safe and effective drug therapy management beyond just dispensing of the medication product.